everybody hear me okay? So the next 30 minutes or so, we'll talk about ultrasound-guided interventions in the musculoskeletal system, a little bit about some background, some key technical considerations. We'll talk a little bit about just to review what musculoskeletal tissues look like on ultrasound, and then we'll go through a series of clinical examples. So why use ultrasound? Well, it allows excellent depiction of the soft tissues, tendons, muscles, and so forth. Very important, it's tomographic, so it allows us to look at the needle stereotactically, so we know where the needle tip is relative to the soft tissues. Most importantly, however, it's real time, so that always allows us continuous monitoring of the during needle placement, as well as following both the distribution of injected material, as well as looking at the aspirated material that we're doing. And very importantly as well, since a lot of times we're asked to do procedures on patients who have indwelling hardware, it's not really subject to metallic artifact that you would see, for instance, in MR and CT. So that's really an advantage. What's important in doing musculoskeletal ultrasound in general and doing these procedures is to be very familiar with the type of equipment you have, understand scanning techniques for musculoskeletal soft tissues, how to optimize your images, what optimal transducer to choose for the type of procedure you're doing, and of course having a good knowledge of the sonographic anatomy. So let's talk about, just to review a few things about what normal tissues will look like on ultrasound. So as opposed to seeing a low signal intensity structure that we would see if we were looking at an Achilles tendon or tendons anywhere, on ultrasound, tendons appear as echogenic fibrillar structures as we see in this Achilles tendon as it inserts on the calcaneus. This is fairly characteristic. But also what's very important is tendons display a property known as anisotropy, which means if we look at this Achilles tendon in cross-section, if we look at this little inset over here, if this is the long axis of the tendon, and the beam is insulating perpendicular to the tendon axis, we get the maximum backscatter to the transducer, which maximizes the echogenicity of the tendon, giving that nice bright elliptical appearance that we see in this image over here. However, if we tilt our transducer, and it could be as little as 5 degrees off axis, the tendons will become progressively more hypoechoic. That's a property known as anisotropy that many of you probably have heard about. And something we need to be aware of, particularly when we're doing interventions, because we don't want to misinterpret a normal soft tissue structure as being fluid and inadvertently do an intratendinous injection. So that's something we always need to be aware of. Muscle, on the other hand, as opposed to being echogenic and fibrillar that we saw in the tendon, muscles normally appear hypoechoic. So in distinction to the sort of intermediate signal intensity that we would see normally in a proton density image of a quadriceps, we see muscle appearing as hypoechoic. The epimysial soft tissue appears echogenic as opposed to low signal that we would see, or dark that we see on an MR. And most fibroadipose structures that we see within the muscle appear echogenic. That's those perimysial connective tissue, and tendons themselves as this central tendon within the quadriceps muscle that we see over here appears echogenic as well. So these structures are normally echogenic, whereas the normal muscle tissue itself, the fascicular muscle tissue that we see, is normally hypoechoic. Bones appear as strong specular reflectors that have a posterior acoustic shadow, so that as we see in the metacarpal phalangeal joint over here, we see it as an echogenic reflector with a posterior shadow. Same thing is true for any other joint, so go back over here for a second. So the hip, again, we see the femoral head as being a strong specular reflector, and joints we see as sort of like the junction between two smoothly marginated cortical surfaces, and what we may see is a thin hypoechoic band paralleling the cortical surface. So it's important not to interpret that as fluid. That's really just articular cartilage, and so we should see that as a normal appearance within the joint and something to be aware of. Now, nerves have a characteristic appearance on ultrasound as well. I like to call them, when we look at them in cross-section, as in this ulnar nerve over here, I like to think of them as sort of a cluster of grapes. You see the hypoechoic nerve fascicle surrounded by epineurial connective tissue, which appears as sort of like a little echogenic halo around each nerve fascicle, and those are surrounded by the outer epineurium. And so when you look at it in a cross-section, just the way you're looking at it, this schematic over here, it looks like a little cluster of dark grapes, as you might use to make wine, for instance, in France. But when we turn our transducer 90 degrees, we notice that these have a more sort of longitudinal orientation, so it has sort of a characteristic tram track appearance. So those are the kinds of words that sort of used as descriptors to look at when we see nerves. Now, in general, when we do procedures on ultrasound, I like to use a freehand technique. So, and whenever you're using a freehand technique, you really want to optimize how you choose your transducer and how you approach the area of interest. So ideally, we want to make the needle look like a strong specular reflector. And metal is very characteristic on ultrasound. So here we have, let's see if we can find the arrow here, a needle going into a small cyst, and you notice that it's a strong specular reflector and has a very characteristic reverberation artifact. So metal is very easily recognizable when we do ultrasound, and so it's very easy when you're doing these procedures in real time to recognize any kind of metallic structure, whether it be due to an arthroplastic component or in this case due to a needle as it's approaching. And it's really, it's a very nice way to see these on real time when you're doing these procedures. And as is true with any kind of sterile procedure, you're going to do things sterilely. So you're going to have a tray that's appropriately modified as the way you would have a specific tray to use for a fluoroscopic procedure. We have a specific tray that we use for ultrasound-guided procedures with sterile gel and appropriate drapes. So you want to drape the transducer as well as sometimes the scanner as well. Okay, so let's talk a little bit about some nomenclature. You're going to hear me use two terms, long axis and short axis when I'm approaching structures. And what do I mean by long axis? I mean parallel to the long axis of the structure. So it could be a joint, it could be a tendon. And a sort of characteristic example of that is if I'm doing a hip injection as I'm doing over here. So when I put my transducer over the thigh and I'm looking at the hip, and as you can see in the sort of sagittal image of the hip on MR, we're going to see the femoral head and neck junction. We're going to see the long axis of the joint, the acetabulum sitting over here. And this would be the plane that I'm going in along the long axis of the joint when I'm placing my needle. So that's what I mean by a long axis technique. Short axis, on the other hand, is just the opposite. I'm going perpendicular to the long axis of the structure. So the typical example of that would be doing a retrocalcaneal bursal injection. So if you look at this image over here, where I'm doing where the Achilles tendon is in this direction over here, this is the heel over here. My transducer is placed perpendicular to the long axis of the tendon, and my needle is coming in perpendicular to that. So it's along the short axis of the tendon. So you can see what that would look like in a schematic over here. Here's the tendon seen in cross section, and my needle's coming in perpendicular to that structure over there. So that's short axis technique. So hopefully that is a little bit self-explanatory. So typical examples that would be, as we see here, a retrocalcaneal bursal, or a lot of the small joints that we'll see in the type of small joint injections that we do that I'll talk about in a few minutes. And of course, injections are always performed in real time. That's one of the beauties about ultrasound, so we can always monitor the material as it goes in. Let's hope this works. There we go. So you can see distension. When we're doing these injections, you see distension of the dorsal capsule of the joint. You see microbubbles filling the capsule, and so we know we're intra-articular. Now there are two types of contrast. So there's contrast that we attain from microbubbles themselves, but usually because what we're injecting is a particulate steroid, something like Kenalog or Depomedrol, which is particulate in nature. It actually has its own intrinsic contrast. And let's see if I can get to the next slide here. So if this one works, you'll see that this is actually me injecting a dorsal ganglion cyst within the ankle, and you notice that there are no microbubbles in here, but this is in fact the injected steroid itself. And this is due to the fact that there are acoustic differences and impedance differences between the material that we're injecting and the background of fluid that it's sitting in, whether it be ganglion cyst fluid, synovial fluid, or simply anesthetic. And in fact, we looked at this a few years ago a little more systematically. So this is a tissue mimicking phantom with a cyst within it that's completely anechoic. And when you inject this material in there, you get a mixing phase where this stuff distributes fairly uniformly. And you can see the internal contrast just by virtue of doing the injection with the steroid mixture itself. And you can tell that because this is particulate, you suspect it would settle over time gravitationally. And in fact, that's what we see. When we look at this later image over here, we can see that there's sort of drop out along the superficial part of the cyst and then some increase that goes towards the bottom. And in fact, we could show this as over time. This is just looking at the same cyst phantom over time. This is the background over here. This line over here corresponds to the upper half of the cyst. This is the lower half of the cyst. And as you would expect, the upper half of the cyst falls off fairly rapidly. The lower half of the cyst stays up higher and then eventually falls off because not only is it losing material, but it's also gaining it from the upper half of the cyst. So that is exactly what you'd expect to see if it's simply a gravitational effect, it's particles settling within the fluid. So we know that's actually a contrast effect from the material that we've injected itself. So what types of procedures do we do? Well, we do virtually everything on ultrasound. Joints, and in fact, I've converted some of my colleagues at NYU so that they're using more and more ultrasound. Even Leon's doing more ultrasound these days, which is amazing. So joints, cysts, various types of neuromas or peroneal injections, intratendinous injections, which we'll touch about a little bit, and muscle and arthroplasty, just simply to give you a few examples, and we'll talk about that in the remaining time. So for joints, I like to separate those out into small joints, small to medium-sized joints, such as foot and ankle, hand, wrist, and elbow. And we tend to use a small amount of steroids, something on the order of 10 to 20 milligrams of triamcinolone or methylprednisolone, which is depomedrol. Most of these I do a short-axis technique, and I do these injections with a 25-gauge needle and a high-frequency linear transducer. So the typical example of that would be the first metatarsal phalangeal joints. Patients come in with arthritis in the great toe due to hallux rigidus or a bunion deformity. And so this is what that would look like. So here's the first MTP joint, a joint body situated over here, first metatarsal proximal phalanx. Here's my needle sitting in, that I placed in short axis, so you see a characteristic reverberation artifact, so we know it's due to metal. And then we see, then I've done my injection, and you see the extension of the dorsal recess that is indicated by this arrow over here, and you see the low-level echoes within the distended dorsal recess due to the contrast effect that we mentioned earlier. And of course, we, like any other injection, as I said before, we would, oops, let's see if I can do this. There we go. If it works. Maybe. No, this one doesn't want to work. Okay. Anyway, here's my needle. Here's my needle cross section, and if the ABI file worked, you would see the extension of the dorsal capsule. So we'll go on. So let's look at another type of small joint injection. This is the basal joint of the thumb. A lot of people, common location for arthritis, and whereas I've done a fair number of these types of injections. So what this looks like on ultrasound is here's the base of the first metacarpal, the trapezium over here. This is corresponding to what we see in the radiograph. So when we look at this systematically, here's the joint. And then what we see is the joint with my needle sitting in it, is indicated by the arrow. And then we do our injection, and then you expect to see dorsal extension of the dorsal recess filled with those low-level echoes due to the contrast effect that we mentioned earlier. Okay, so the large joints typically are the hip and the shoulder. There are a variety of indications. Actually, I do a fair number of our MR arthrograms under ultrasound guidance, so I include that in our list of indications. Then you usually use a long axis approach, use a larger dose of steroids depending on the indication that we're going to be using it for. And the patient, depending on the patient body habitus, a lot of times I do this with a relatively intermediate frequency curve transducer, but you may need to use a sector transducer, particularly if the patient's relatively large. And on occasion I've done these in 300-pound patients. So, although I think I probably do more fluoro sometimes for the heavier patients. But let's see what this looks like. This is the long axis approach that we saw earlier, where the needle goes into the femoral head-neck junction. Usually what I'll do is I'll inject a little bit of air or a little bit of lidocaine, which has a few little microbubbles in it, so we're looking for a little bit of fluid distension of the anterior recess we know we're in. Also, it'll feel right as well. When you start doing injections, you sort of gain, one of the things that it's hard to demonstrate, but you really need to feel it, is what it feels like to inject a joint or a bursa or whatever, very little resistance. But when you see that, you know you're in the joint, then you can put in the therapeutic mixture, and then you see distension of the joint capsule. You also may have redistribution of the microbubbles to the non-dependent surface of the joint, as indicated by the letter L over here, where we have some microbubbles outlining the anterior superior labrum. So we can sometimes see those structures very well as well. For glenohumeral Femoral joint injections, which is the other more common large joint injection that we do, usually put the patient in the cubist position. As indicated in the schematic on the upper left, my transducer is placed posteriorly. I place my needle in deep to the infraspinatus muscle below the capsule, and you can see what this would look like in this image over here. So what this would look like in ultrasound is you see the needle coming in below the posterior capsule, right over the articular cartilage. And if this works, hopefully it will, you'll see distension of the dorsal recess, and you see these low-level echoes going in as we're getting that contrast effect, so the material is flowing away from the needle tip. And usually I do this with a 1.5 inch 25 gauge needle in most patients, so it's fairly simple to do. So bursa are another things that are very minimal to ultrasound guidance, because after all they're fluid collections, and we see fluid very well in ultrasound. I like to distinguish between what I call deep bursa and superficial bursa. The deep bursa, of course, are things like Baker's cyst and iliopsoas bursa, whereas the superficial bursa we saw an example of before. That was the retrocalcaneal bursa, or most tendon sheaths, because particularly in the hand and wrist and foot and ankle, they're very close to the skin surface. And again, for the small structures, I'm going to use a 25 gauge needle, a short axis technique, whereas for the deeper structures, it can be somewhat more variable depending on the orientation and body habitus and so forth. So here's a typical thing that we might be asked to do. This is sort of like a bread and butter type of procedure. This is a patient with a large Baker's cyst in the posterior medial aspect of the knee. And it's good to aspirate and inject these things, because if they rupture, they can be quite problematic, as many of us, I'm sure, have experience with some of our patients. So I'll usually use a 20 gauge needle, go in using a short axis technique, and then simply aspirate it and leave a little bit of steroid and anesthetic in there. And these patients usually do quite well, and occasionally they'll come back for a repeat, for a return visit, just because it's much better to do that than wait till the thing ruptures and have to deal with those complications. Now, iliopsoas bursa, most of the time when we're asked to treat these, it's in a non-distended bursa. The patient has either potential problems associated with anterior groin pain, or they may have an indwelling prosthesis, and the question is, do they have a secondary iliopsoas tendonitis or bursitis? And a lot of times at the bursas, there's no distension of the bursa at all. So we really are asked to fill the bursa rather than simply aspirate it. And so this is just to go over the anatomy. Usually we see the iliopsoas tendon, sort of a low signal intensity area situated anterior to the joint capsule at the level of the iliopectineal eminence. What it would look like on an ultrasound is this is sort of an echogenic structure sitting on top of the acetabulum here. Here's the femoral head, an echogenic anterior capsule, and overlying iliopsoas muscle here, and pectineus muscle situated just more medial to that. So what this would look like is here's our baseline anatomy. I'll place my needle in using a lateral approach, going deep to the tendon, right, using the iliopectineal eminence as my target. So it gives you a nice bony landmark to go for. And then you're going to just do a test injection with lidocaine or some anesthetic, and you expect to see filling of the bursa as we see in the lower left-hand side. This is a little bit of fluid collection over here. And also should feel right. You know, it should go in fairly easily, and then you pretty much know you're in the right location. And then you can put in your contrast as indicated over here. You're getting that swirling effect due to the contrast effect that we spoke about earlier. So again, it's a fairly straightforward injection to do. This is the kind of scenario that we might be asked to do on occasion, which is actually not that often. But this patient this is a 69-year-old female with left hip pain. She has an indwelling arthroplasty. She developed groin swelling and she developed weakness. And if you look carefully in this MR, here's her femoral vessels over here, but this structure over here, which looks flattened like a grape, is in fact her femoral nerve, because it was displaced. And you can see this is a sagittal image showing what this would look like on MR. I can get my arrow over here, so that's that. Notice that there's a lot of susceptibility artifact over here. If you look at the corresponding extended field of view image on ultrasound, you see the characteristic artifact due to the fact that there's a metallic femoral component, but notice that there's no difficulty in seeing the overlying distended bursa. And so we were asked to aspirate this. So here's the iliopsoas bursa. You can see how complex it is. And there's the femoral nerve, and we can avoid that because we know what it looks like on ultrasound, and we can go to the various cystic components and aspirate these fairly easily under ultrasound guidance, which again is a very nice aspect of ultrasound, since we can see all these neurovascular structures. The short axis approach I said before is typical of what we do for small bursa. This is that retrocalcaneal bursa, again, taking a short axis approach perpendicular to the long axis of the tendon. We usually place our needle into a little bit of fluid deep to the tendon. If we see it, we can do a test injection with lidocaine. Make sure you're distending the bursa as indicated in this image here, and then we can inject our steroid. If I rotate my transducer 90 degrees, I'm going to see exactly what I would expect. I'm going to see the fibril appearance of the tendon, the distended bursa, and we see the reverberation artifact of the needle seen in short axis. So that's exactly what I meant by that short axis technique earlier. So for biceps tendon sheaths, it's again another common indication for doing ultrasound-guided injections, particularly if you have fluid distension within the biceps tendon sheath itself. We take a short axis approach. So as indicated in this MR over here, we come in laterally. Here's the tendon sheath, the biceps tendon within the bicipital groove, and the tendon sheath surrounding it. And so this is what we might see on ultrasound over here. Here's the tendon, which looks fairly abnormal, and here's the distended tendon sheath. I'm going to place my needle in, and since we have fluid distension, it's very easy to avoid an intratendinous injection. And then we're going to aspirate with fluid we see, and then inject the material, and we expect to see that contrast effect within the tendon sheath. Now, we don't always have the benefit of having fluid distension of the tendon sheath. So what do you do if there's no fluid distension? Well, what I found, approach that I've been using of late is actually going directly into the rotator interval. Now, as indicated very nicely by Dr. Steinbeck, if you look at the rotator interval, there's a biceps pulley mechanism that surrounds that. So we have the biceps tendon as indicated on the sagittal MR over here, and we have two ligamentous structures, one overlying it that goes deep to the tendon. This is portions of the coracohumeral ligament, as well as a more deep portion, which is the superior glenohumeral ligament, which is indicated by the arrow here. That's the coracohumeral ligament that goes into that that has a deep component that goes deep to the rotator cuff tendons. And so this is what this would look like on an ultrasound. We're basically going to move our transducer a little bit more proximal up in the shoulder, so we're seeing that intra-articular portion of the tendon and come in using a short axis approach. So this is what that looks like. Here's the tendon over here. I usually sometimes will blow the transducer a little bit, so I'm getting a little bit of a long axis approach on the tendon. I tend to like to go superficial, so deep to the coracohumeral ligament. And again, you're going to do a test injection with lidocaine or some anesthetic just to make sure it's going in easily. And then usually it's a fairly simple injection to do for the most part. You can check to see in the bicipital groove that you have distension of the tendon sheath. And in fact, if you see the contrast effect, it's usually it sort of helps confirm that the stuff went where you wanted it to go. And oftentimes you'll have distribution of the injected material or injectate within the rotator interval itself, which can be very good because a lot of times bicipital tendonitis or tendinosis actually originates within the rotator interval itself, particularly in patients who have like early adhesive capsulitis. They have this extensive scarring that occurs right in the rotator interval. So the same concept can be applied anywhere within the musculoskeletal system. Foot and ankle is a very nice location. We're asked to do a fair number of these types of injections. This is a patient with medial ankle pain. This is an abnormal posterior tibial tendon. There's a distension of the corresponding tendon sheath, and this is usually, we see this best in the inframiliolar region of the ankle. Here's you can see my needle going into the tendon sheath. Do a test injection, make sure it's going in easily, and then when I put in the steroid, I expect to see the contrast effect as indicated very nicely over here by these low level echoes. And then I can do my injection, and I see full distension of the tendon sheath. And you get some secondary gain here because not only do you see the margins of the tendon very nicely, but sometimes you can see areas of nodular synovitis and thickening of the tendon sheath as indicated here. So it gives you a little bit of a secondary tenosyllographic effect that can sometimes be helpful diagnostically. Here's a longitudinal image of that same posterior tibial tendon. Decurvain's tendonitis, of course, is a stenosing tendonitis or stenosing tenosynovitis that we see in the first dorsal compartment. We have enlargement of the first dorsal compartment tendons of the wrist, as well as thickening of the overlying extensor retinaculum, so it can be quite thickened at times. And again, I approach these using a short axis approach, usually slightly distal to the radial styloid. So you may see a little bit of fluid that can help you out. But what's nice about ultrasound is you can avoid the adjacent structures. So we've avoided the cephalic vein here very nicely. There's a recurrent branch of the radial nerve that comes over there, which you can see fairly easily. So these things are relatively easy to avoid. avoid. And here's my needle going to the distended tendon sheath, and we do our injection, and then we have nice extension of the tendon sheath with steroid and anesthetic. And but to some extent, you're performing hydrodistension of the tendon sheath, which sort of stretches out that retinaculum as well. So you're helping, just by virtue of putting fluid in a situation with stenosing tendonitis, it can be very helpful. Now I'm in a position where I get to treat a lot of ballet dancers, and of course ballet dancers can get a stenosing tendonitis, but usually in the flexor hallucis longus tendon, along the medial aspect, posterior medial aspect of the ankle, and they can have a variety of problems. But abnormalities of the FHL is one of the indications for that I'll frequently see these patients for. Due to extremes of plantar and dorsiflexion, they're apt to develop a sort of chronic tendinosis there. And so I will approach these tendons when I'm asked to do that type of injection with a patient prone. I should scan medially and come in laterally. So it's a little bit counterintuitive, but you'll see why that is in a moment. So if we look at an MR to see what the anatomy is, we could see that the FHL sits in the posterior sulcus. There's a neurovascular structures here. I'm scanning medially, I'm going to come in laterally. That way I can avoid those neurovascular structures. So if you look over here, this is what the corresponding ultrasound image looks like. There's my needle going in lateral to the Achilles tendon, deep to the FHL, and then I'm going to inject, and I see distension of the corresponding tendon sheath. And it's a very nice approach. That way you avoid the neurovascular structures, and you can do these injections fairly simply. And so it's a nice way. I find it better than fluoro. I can't imagine doing that fluoroscopically. Ganglion cysts are, again, another common fluid collection that we see in the musculoskeletal system. They're common in the hand and wrist and foot and ankle, although we can see them anywhere. They have this really thick gelatinous material. So this is sort of one standard type of cyst we might see in the dorsal aspect of the ankle. This is the dorsal talonavicular joint with a large unilocular cyst. And this is fairly easy. I mean, this could probably have been done clinically, but you can see very nicely our needle going in, a reverberation artifact, and then since we're looking in real time, we can see that we can look at it as the cyst diminishes in size, and I may leave a little bit of steroid and anesthetic in that. Where we become particularly useful to the clinicians, or not so much the last case, but really this case, this is an occult dorsal ganglion cyst, and these can be quite symptomatic. This is a longitudinal image of the dorsal aspect of the wrist. This echogenic structure here is the dorsal scapholinate ligament. We have a small cyst over here, and these can be quite symptomatic because they can cause massive effect on the posterior interossei nerve. And again, you know, ultrasound is a very convenient way to do it. You can see in the lower image over here, my needle going into the cyst as we're going to do an aspiration and injection. So again, it'd be hard to imagine doing this any other way than ultrasound. Another type of sort of similar cyst that we see is these parameniscal or paralabral cysts. These contain fairly thick gelatinous material, but they also contain a lot of meniscal or fibrocartilaginous debris within them. This is a patient on the right with obviously osteoarthrosis with a bad left parameniscal cyst. And in the knee, it's usually more mechanical issues that give rise to their clinical symptoms. But again, this is fairly easy to aspirate and inject. I typically would do this using a short axis technique and maybe an 18-gauge needle because this stuff can be fairly thick. The more problematic ones, of course, are the ones in the shoulder because they can actually have a compressive neuropathy by compression of the suprascapular nerve, whether they occur superiorly in the suprascapular notch or posteriorly in the posterior spinoglenoid notch. This is the large suprascapular cyst that we see over here, which can cause which give the patient the weakness due to suprascapular nerve compression. And here's my needle coming in using a suprascapular approach directly into the posterior aspect of the cyst where we ultimately aspirated and injected. This is a patient with a more typical type of cyst that we see in the spinoglenoid notch. And just to review the anatomy with you, this is what this would look like in the MR. This is posterior sulcus here. On the ultrasound, I'm going to see that posterior sulcus. Here's the humeral head. So we're scanning posteriorly. Here's the big cyst that we see over here. And indicated by the asterisk. There's my needle placed into the cyst. There's the tip of my needle sitting in the cyst, so I know I'm in the right location. And then I'm going to do a series of lavages and aspirations of that, and ultimately leave a little steroid mixture. So there's, you can see that cyst is now filled with low-level echoes due to distension from the corticosteroid anesthetic mixture that I placed into it. So we're going to end up with a few miscellaneous types of injections that we do fairly frequently. Probably Neuroma is actually one of the more common injections that we do at our institution. They're fairly common, although there are a variety of post-traumatic reasons for having various types of neuromas as well. We're doing more and more perineural injections in our practice, as well as doing intratendinous injections, usually in the form of platelet-rich plasma injections. So let's look at some of these. Morton's neuromas are these hypocoque nodules that we see in the second and third web spaces, and we may see a thickened nerve, as in this particular case, going into this neuroma. And we approach these, usually either a dorsal or plantar approach will suffice, but I'll go into them with a short, and a long axis approach with a 1.5 inch 25 gauge needle, and I inject the same amount of steroid I might with a small joint. So typically something on the order of 10 to 20 milligrams of something like triamcinolone. And so that's what this would look like. Here's my needle within the neuroma, and you notice the neuroma looking more echogenic because of the contrast effect that we mentioned earlier. The same thing would be true for neuromas elsewhere. This is a patient who had an anterior compartment release. She was a runner, and what happened is it's fairly close proximity to where the superficial peroneal nerve is, and so she developed this small, fairly symptomatic neuroma over here. So we were asked to just inject around it just to confirm that that's where her symptoms were, and so it's fairly easy to target under ultrasound. As you see with our needle over here, and then we do a perineural injection or perineuromal injection, as in this particular case. You can see very nicely with the distribution of injected material. Carpal tunnel syndrome, in fact, we did one of these yesterday in the other place I gave a talk at Dr. Shepson's hospital. This is a fairly nice injection to do. Patients come with idiopathic carpal tunnel syndrome where you have enlargement of the median nerve, and it's fairly easy to, when you see the nerve, to place the needle in a perineural distribution in order to do sort of hydrodissection around the nerve. So here's what I generally do. You can see the nerve very nicely. The nerve looks sort of enlarged and somewhat more hypocoque. You lose that internal morphology. We go in through a radial approach and go adjacent to the epinurium, and basically you're going to do hydrodissection around the nerve and inject around it with the anesthetic steroid mixture. And these patients actually do quite well with these types of injections. So this is what this would look like after you do the injection. You can see the nerve and the epinurium, and you see all the fluid dissecting around. And usually dissects both proximal and distal in the distribution of the nerve fibers, or the nerve itself. Now, we can use the same technique regardless of where we are. You do a fair number of small nerve perineural injections. This is actually a nerve block we were asked to do on a patient with suspected superficial peroneal nerve abnormality. Again, these nerves can be quite small, but we see them very well with ultrasound with a high-frequency transducer. So basically what you're going to do is place your needle just adjacent to the epinurium, and then you're going to inject around it, try to do dissection around that nerve with an anesthetic. Could either be anesthetic such as 0.75% Marcaine or something that contains steroids such as celestone or dexamethasone. And this is what that would look like afterwards. You basically want to dissect right along that nerve long axis, and you'll see the fluid sort of dissecting. And again, ultrasound allows you to monitor that as you're doing the injection to make sure it's in the distribution you want to keep it in. So intratendinous injections are things you may have read about. Autologous blood, fenestration, PRP injections, stem cells, they all sort of fall into the same category. Basically, what you're going to do is use ultrasound guidance directly into the area of tendinosis. You're going to fenestrate the tendon. Let's see if this works. That works nicely. This is the patient with lateral epicondyle. So you're going to fenestrate it. You're going to cause a bleeding response. You're going to start an inflammatory process, which is that inflammatory cascade that helps healing. And you're going to have release of, it's going to cause bleeding and release of platelets, and platelets have the growth, alpha granules, which have all the growth factors that help promote healing response. So we can help augment this procedure by simply adding a little bit of blood, or even to be a little bit more specific about it, taking the blood, spinning it down, removing the so-called buffy coat layer, which contains the platelets, and so we're going to deliver the platelets in much higher concentrations. And that's exactly what we're doing when we do platelet-rich plasma injections. We're taking those high concentrations of platelets, we're going to deliver it directly to the tissue, and we're going to deliver those growth factors that promote a healing response. And there have been a number of studies, in fact, show that there is some efficacy in doing this to some extent, depending on what location you're in. Certainly in patients with lateral medial epicondylitis, it works fairly well. So here's another patient with a proximal tear, and let's see if this works. Here's doing fenestration. You notice all these little bright little echoes throughout the soft tissue here, and that has to do with some microbubbles within the injectate that help distribute with the tendon. And sometimes it can be very helpful because it lets you know where the injected material is distributed to. So let's see here. So just to give you an example, one of the good applications is hamstring tendon origin. So this is the 61-year-old female runner with buttock pain. This is her common hamstring origin. She has a large tear over here. This is, let's see if this works. It should work, it's a Mac, right? No, I guess it doesn't want to work. Anyway, so this is her 3 months later, and what happens, you can notice that this is her tear over here. Initially, this is what it looked like 3 months after doing the PRP injection, so she actually had a very nice response. And hamstring is actually one of the places where we've seen fairly good response, and we actually recently completed a double-blind study with using just simply autologous blood, and these patients do considerably better in the PRP cohort. So we know that there's some efficacy for doing these types of procedures. This is a professional dancer, a 24-year-old professional ballet dancer with acute onset of lateral ankle pain. This is her MR. You can see her peroneus brevis and her longus over here. Her brevis is very abnormal. This is it on ultrasound. You can see it's thickened and homogeneous with a longitudinal split tear. And here's doing a PRP on her. You see it in both long and short axis. And if you look at her follow-up, just to give you a baseline, this is her baseline image over here in long axis. You can see the tendon is very abnormal. This is 4 months later. You can see the tendon now has much more improved morphology and thickness. She symptomatically was much better, and she was able to dance again at a high level. And she's a principal in one of the New York City one of the major dance companies in New York. So it's fairly strenuous activity, as you might guess. Calcific tendonitis is another area where we're very amenable to treat under ultrasound guidance. This is calcium hydroxyapatite, usually within the rotator cuff along the superficial margin. And this is we see the large majority of these within the supra and the infraspinatus tendon, as indicated over here. These are very amenable to percutaneous placement of the needle. We do a lavage technique where we place a needle in, lavage initially with anesthetic, subsequently with sterile saline, and then we will usually give the patient an injection in the subacromial subdeltoid bursa. So we use a single needle technique, and so what this typically looks like is, we'll see if that works, is we use the fact that there's an intact pseudo capsule, so we're lavaging that and basically using the internal pressure within the cyst itself to decompress and basically help empty out the calcification itself. And then we'll fenestrate it, and then we'll ultimately leave a little bit of cortisone and steroid into the subacromial subdeltoid bursa, because they have a very significant inflammatory response as the calcium leaches out into the bursa. So this is what this material would look like on an X-ray. So just to give you an example, we may go anywhere from 8 to 10 syringes of this, depending on how large the calcification is. So it could be fairly significant, but these patients do remarkably well. In my own experience, we follow these patients, 40 or 50 of these patients out 3-4 years, and we had 75 to 80% of them had good, excellent results. So that, based on clinical outcome measures, and so these patients can do quite well, and very few of them have to come back for reaspiration. I'm just going to mention a little bit about muscle. Muscle is one of the areas that's somewhat controversial. There's really no good definitive data out there, but at least anecdotally, I can say in my own experience, and I think in the experience of others who do these, that these patients can do quite well. This is an example of and this is just simply for aspiration, but also for injection of steroid as well. This is a patient with it's a seroma in the rectus femoris muscle over here. You can see my needle going into the seroma portion of this thing. This is a patient who had difficulty rehabbing, and he had a $250 million contract. So as you guess, they would want to have him back to playing. We simply aspirated this, in 24 hours he was back to normal play. So you can actually see that this really can have a significant impact. So I want to finish off just for the next minute or so with joint implant complications. There are a variety of procedures we can do, the same things we spoke about so far, and as I said before, metal doesn't interfere with us at all. So this is a 49-year-old female with groin pain and suspected iliopsoas tendonitis. Here's my needle coming in laterally deep to the iliopsoas tendon. Certainly doesn't impede us that she has an indwelling arthroplasty. There's fluid in the bursa, and there's a long axis showing fluid distension of the bursa around an abnormal tendon. Finally, we have this patient who has obvious osteolysis around their arthroplasty. And you can see there's a fairly thickened anterior recess, and there's a femoral component sitting over there, so it doesn't affect our ability to see that complex fluid. There's my needle going into it. There's a tip indicated over there. We got 45 cc's of purulent material out of that joint. So again, didn't affect our ability to do this aspiration, and we could give the clinician an answer almost immediately. So in summary, hopefully I've given you a fairly extensive overview of what ultrasound's capable of. The important things is to be familiar with scan techniques, know your ultrasound anatomy, and then know how to optimize your images, and I think you'll have a very successful time doing these types of procedures. So I thank you very much.